Hello, my name is Nicholas Allen. I am the Associate Director of Athletic Training for LaSalle University in Philadelphia, Pennsylvania. Today's topic will be on therapeutic joint mobilizations and manipulations. After this presentation, the viewer should be able to be more proficient in delivering therapeutic joint mobilizations and manipulations to their patients. Learning objectives. After this presentation, you'll be able to identify the different techniques associated with joint mobilizations and manipulations, describe the physiological response achieved from the use of mobilizations and manipulations, and identify when and when not to use mobilizations and manipulations. Background and history. We'll start with the definitions. Manipulations are defined as manual procedures involving direct thrust to move joints past physiological range of motion without exceeding limits anatomically. Mobilizations are singular or repetitive movement applied within or at physiological range of motion without thrust or impulse with the goal of restoring mobility. Joint mobilizations and manual distractions are both manual therapies, and they're typically used to increase range of motion or decrease pain. Distractions are defined as the vertical distraction or the vertical separation from a concave surface, and it affects neurophysiological and mechanical aspects of pain arc, and muscle spasms. Both use passive accessory movement for the recovery of arthrokinematics. Origins. We'll begin with the manipulation in ancient arts. So the beginnings of joint manipulations are in man itself. So in the past, humankind has performed self manipulations and releases without really knowing what they were. This stemmed from cracking the joints in the fingers, the back, pulling the shoulders back, knees to chest stretching hamstrings, and then cracking lower back. So people commonly do these things daily and don't realize that these are considered joint manipulations, but they are for a form of joint manipulations. Back in pre-recorded history, before history was taken, there has been evidence of in the Asian continent of back walking, and which is another primitive form of manipulation. And there's also been evidence of Native American tribes who have skillfully practiced resetting bones in their warriors who were injured from either battle or from hunting. The first written documentation of any kind of medical procedure involving manipulation or mobilization came back between 460 BC and 355 BC with Hippocrates. Hippocrates is considered the father of medicine. That name may sound familiar through the Hippocratic oath that doctors take, which basically says they won't cause any harm to any other patients. He first described joint manipulations and tractions. He wrote, one of his writings was on setting joints by leverage, and he's written several papers on techniques on reducing dislocations, mostly on shoulders, mainly because back in his time, wrestling was a real popular sport, and the most common injury seen in that time during with wrestling was dislocations of the glenohumeral joint. So a lot of his writings were on reducing those kind of injuries. Then we move ahead to Middle Ages and the Renaissance. The actual medical knowledge started to decline at this point, and people got all their medical help from the church. Interesting fact, St. Lawrence was appointed into sainthood, and he was the saint of backaches and remained the saint of backaches from the Middle Ages until about 1970 when he had that title removed. Um, Medicine in the Renaissance started with Andreas Vesalius. He was the first known person to describe the human body anatomy, and he outlined the anatomy of the spine and the intervertebral disc way back in 1543. In 1579, Ambrose Pare was one of the first well-known surgeons. He was a surgeon of four kings, and he used a lot of the manipulation techniques described and written down by Hippocrates from 400 BC, from the late to early 300 BC. Then we moved to the dawn of modern medicine, which was about the mid 18th century. We have John Hunter from 1728 to 1793. He wrote about the value of joint movements, especially after injuries, to prevent the muscle adhesions. He wrote that any adhesions remaining in the body after injury was a product of inflammation and should be stretched out. Um, then Andre coined the term orthopedic. It's a Greek word which breaks down into orthos meaning straight and pedos meaning child. In the late 18th century, you have Hay describing the manipulation of semilunar cartilages of the knee, and the condition being knee pain condition being relieved by resting the knee in the normal rest position, which is in between flexion and extension. In the late 18th century, around 1784, Harrison developed a reputation for using manual procedures. One of those manual procedures was the joint manipulation. So he became real popular for using joint manipulations to help people through their pain and other ailments that they had. And then in the 17th and 18th century, we saw the use of bone setting, especially in Britain. The thought was that little bones would come out of place, the smaller bones would come out of place, and manipulation would get them set back into place, and any popping or cracking you heard from the manipulations were those bones sliding back into place. This theory and thought process died out in the mid 20th century. But before then, it was a real popular concept, and Warren Hood even published a book on the whole process and topics of bone setting. But people started slowly believing that the manipulations from bone setting was actually not the bones itself setting, but the release of adhesions in the muscles. So we move ahead to techniques. There are three types of joint mobilizations: oscillations, sustained mobilizations, and manipulations. Oscillatory joint mobilizations are repetitive passive movements varying in amplitude and generally of low velocity. So it's getting that separation in the joint, but slow and steady. It's not a real hard pull or a real fast motion. Then you have sustained joint mobilizations. It's a traction type movement, decreasing compressive forces on the joint or distracting the articular surfaces and taking up slack of the surrounding soft tissue. So this is more of your distraction and hold techniques. Just getting that separation between the joints and holding. And then finally, manipulation. Manipulation is an additional manual therapy involving sudden high velocity thrust movements of small amplitudes at the limit of available movement. So manipulations are kind of like oscillatory joint mobs, but they're faster and there's more force behind them. And they're not repetitive. So you're not gonna put that high force, a high velocity behind the pull constantly in a repetitious motion. You're just gonna get one strong high velocity pull with that joint separation, and then you're gonna relax. Joint mobilization facilitates the five arthrokinematic motions: roll, spin, slide, compression, and distraction. Um, so the joint, the syn- synovial joints, when you break down their movement, they're going to move on each other in one of those five ways. Um, some cases they may move more than one of those, or may move two or more of those ways. Um, two primary grading systems for documenting joint excursions during mobilizations. So there's two ways of grading joint mobilizations. You have the Kaltenborn grading method and the Maitland grading method. The Kaltenborn grading method is a three-part grading scale to describe the joint mobilization amplitude. Incorporates traction or sustained joint mobilization and oscillatory joint mobilizations. Um, so it's that hold, that pull and hold, and it's also those oscillatory movements fall into these grades. So grade one is force to remove joint suppression without joint separation. So that's that light, gentle oscillation of the joint, but you're not getting any separation at the joint. Grade two is a force tighten ligament and joint capsule following increased tension. So with grade two, it's another oscillatory, but you're going to get a little bit of separation, just enough to put a little tension on those on that capsule and on those ligaments. Grade three is force necessary to separate the joint surface by adding additional power during grade two and distraction. So grade three is just a more forceful version of grade two. You're going to get a greater separation of the joint surface. So grade ones and grade twos are to control pain, and grade three is to increase range of motion. So for the Maitland is a five. It uses five grades of the movement. Um, they vary in frequency and amplitude. The varying frequencies and amplitudes of the movements utilized depend on the purpose of the mobilization and patient's tolerance to motion. So to choose which one you're going to use depends on what you want to accomplish, whether it's range of motion, control pain, or removal of adhesions, and what the patient can tolerate. Intent of eliminating stiffness or pain in synovial joints. So that's the purpose of using these distractions or manipulations. Physiology and theory. So the anatomy involved with joint mobilizations or manipulations. Of course, you have the bone, you have the soft tissue, the muscles, the tendons, which connect the muscles to the bones, the ligaments, which connect the bones to the bones and make up the joint, the capsule, which surrounds the joint to help hold it together and keep it in the plane of motion it's supposed to move in. The cartilage, which goes in between the endpoints of the bones, in between the joint lines, to take up some of that force so that the bones aren't rubbing against each other, and then the fascia. For the joints, you have synovial joints, so that's like your glenohumeral joint, your tibiofemoral joints, the common joints that have those flexion extension movements or circumduction movements. And then you have the amphiarthrosis joints, so that's like your sternoclavicular joint and your SI joints. Those are joints that have a little movement, just to help assist with the other joints when they move, but they shouldn't move a lot. Those joints do get out of position, and manipulations can assist with returning them back to their normal setting positions. You have your autonomic nervous system. That's the peripheral part of the peripheral nervous system that controls your involuntary actions, such as breathing, heartbeat, you blinking of your eyes. You have your nociceptors. Those are your sensory receptors that detect the painful stimuli. You have your meninges. That's the connective tissue that covers your brain and your spinal cord. You have the nerve root. That's the base of the nerve branching off your spinal cord, coming from the central nervous system. You have your peripheral nerves. Those are the nerves that run out to your your limbs, your arms, your hands, your legs, your feet. Um, and they send the information from your brain to your body and vice versa. And then you have your muscle stretch receptors. These are the receptors in your muscles that relay information to your brain about stretching and muscle lengthening. So you have your Golgi tendon organ. It's located between the muscle tendon junction where the muscle turns into the tendon, and it senses the change in muscle tension. So when the muscle starts to elongate, it senses that change. Then you have the muscle spindle organ, which is located in the muscle belly. Um, it senses the change in the muscle length. So the Golgi tendon senses the tension, the muscle spindle senses the change in length, and it senses how fast that change in length is occurring. If it's occurring too fast, it sends a signal to the brain to tell the muscle to contract to slow that tension down, that change down. All right. For the purpose of joint mobilizations and manipulations is to increase non-contractile tissue, which helps increase range of motion and orthokinematics. It affects the aspect of the neurophysiology and mechanically, neurophysiologically and mechanically of pain arc, and the muscle spasms. So it helps with pain. It helps decrease pain. It helps raise pain threshold levels, and it helps decrease muscle spasms. So general joint play, so those grade 1 joint mobs, it maintains nutrient exchange in those synovial joints, and it prevents painful and degenerative effects of stasis of swollen or painful joints that can't move through full range of motion. So it helps the vascular system get those bad nutrients out and put good nutrients back into the tendons, the muscles, and any of those areas that are not avascular. The neurophysiological effects, small amplitude oscillations and distractions stimulate mechanoreceptors, which may inhibit nociceptor transmission of stimuli at the spinal cord and brainstem levels. So basically, the small amplitude oscillations, they inhibit that pain stimuli transmission from whichever joint you're working with to the brain, which decreases that pain. Mechanical effects, the small amplitude distraction or gliding of joints, are used to cause synovial fluid motion. This brings nutrients to avascular portions of articular cartilage. So it basically brings out good nutrients in, ships bad nutrients out, stretches out the tendons and muscles, and helps gain that range of motion back. Relevant research, you have Braun et al. Studied the effects of rhythmic joint mobilization on the temporomandibular joint to relieve pain and improve function. As in the study, they assessed immediate effects on patients with temporomandibular disorder, TMD. They used 38 subjects with TMD. They assessed them for pain intensity using a pain scale, a self-reported pain scale, pressure pain threshold with an algometer, a mouth opening measure, how wide they can open their mouth. They just measured that with a regular ruler, and they checked the electromyograph activity with the asymmetry index. So what they did, they had a single treatment that was 1 minute long of rhythmic joint mobs on that TMJ to each patient. And the study found that there was a reduction in pain intensity, that pain threshold increased, and patients were able to get a wider range on that TMJ after that one treatment. However, they did not find any difference in the electromyograph activity. The limitations to the study, there was no control group. There was no gold standard to test it against. or a placebo group to test the outcomes against. There was no blinding of either the patients, the testers, or the people measuring the outcomes, and there was only one treatment session. Hoche et al. Studied the effects of 2 weeks of joint mobilizations on those with chronic ankle instability, CAI. They assessed they used anterior to posterior joint moves on those with CAI for 2 weeks, 12 subjects. They assessed the dorsiflexion range of motion with the weight bearing lunge test, dynamic postural control with the star excursion test, and functionality with the self-reported foot and ankle ability measure, PROM. Baseline measures were taken on day 1. Pre-intervention measures were taken 1 week after that. Then they had the 2 weeks of 6 sessions using Maitland grade 2 joint moves each session. And then the final data was collected 1 week after the final treatment session. So the study found alteration in mechanical and functional impairments that was self-reported, dorsiflexion, ROM, and dynamic postural control for at least 1 week. So patients self-reported that their function improved. And then the researchers saw improved measurements with dorsiflexion and dynamic postural control for at least 1 week in all the subjects. Some subjects saw results for longer. Limitations to the study: there was lack of blinding again. The follow-up period wasn't that long. It was only a week. And there was no control group used to measure the results against. Luch et al. Studied the preoperative pain neuroscience education with joint mobilizations for patients with knee osteoarthritis. Their goal was to compare the effects of preoperative treatment, combining pain neuroscience education, PNE, with knee mobilizations to biomechanical education with knee mobilizations in patients with osteoarthritis before and after a knee surgery. 44 subjects were used. They were assessed for pain modulation using an occlusion cuff on the arm, central sensation using a pressure pain threshold with a Fisher algometer, and they self-reported pain and temporal summation using the Western Ontario McMaster's University Arthritis Index, the WOMAC scale, Centralized Sensation Inventory, CSI, the Pain Catastrophizing Scale, PCS, and the Tampa scale for kinesiophobia, the 11 question one, the task 11. Those were all self-reported. So baseline measures were taken during the first week, immediately after the first treatment, and then again 1 month after the first treatment, which was before their surgery, and then 3 months after their surgery. The study found no significant difference between those that did the PNE with joint mobs and those that did the biomechanical education with joint mobs when it came to the self-reported central sensation or with the knee pain and disability, but saw greater improvements with the PNE and joint molds for those that self-reported measures of the pain catastrophizing and the kinesiophobia documents. Limitations for the study: again, there was no control group used, just the two groups with the two treatment groups. There was no control groups or no gold standard they were measured against. The sample size was small, and there was a high risk of subject biasing. All right, principles. So safeguards, some indications for the use of joint mobilizations and manipulations for gentle joint play. So for that grade 1, maybe grade 2, any joint pain, any muscle guarding, any spasms, You can use the grade 1, maybe grade 2 uh, of those joint mobs. For vigorous, so grade 3 of the K joint mobs, or grade 3, 4, or 5 of the M joint mobs. If you're trying to reverse hypomobility, or gain that range of motion back, that's what you want to use those for. Um, so mobilizations with movement or thrust. So that grade 5 or that grade 3, uh, any faulty bone positions, maladapt neuromuscular control, faulty joint tracking. So these are going to be your um, your dislocations, your muscle imbalances, and those what you see when SI dysfunctions. You want to use these to get those back. Distractions and glides for any progressive limitations due to any kind of diseases, and then non-stretch glides or distractions for functional immobility. So if someone's been immobilized for a long period of time in a boot and a knee immobilizer, then you want to use those to help get that range of motion back. Contraindications, any kind of joint disorders such as rheumatoid arthritis, you don't want to use any of these on. If they're hypermobile, um, or some people call it double jointed, um, you don't want to use, you don't want it, those are contraindications for not use these. Any potential necrosis of capsules or ligaments, those there any chance that those capsules or joint capsules or ligaments might be dying. You don't want to use these and cause more damage, cause a rupture. Joint infusing, any swelling or inflammation around the joints due to trauma or disease. You want to stay away from joint mobilizations or manipulations because you might cause more damage to the joint. Again, inflammation, the presence of any inflammation due to an acute or chronic injury or disease. You want to stay away from them because you're going to cause the patient more pain. And then any condition requiring special precautions for stretching. So malignancy, bone disease, fractures, joint replacements, newly formed tissue, connective tissue or weak connective tissue. So like a rupture, someone just recovering from a partial rupture or surgery from a complete rupture, you don't want to do any joint mobs or manipulations on. And then the older population, the elderly, you don't want to do any manipulations or mobilizations on them. Best practices, these are the two measured grades again. So you have a Caitlin Bourne grade 1 to loosen up the ligaments, small amplitude movements, no appreciable joint separation, traction with enough force to counteract any compressive forces on the joints is applied. You got the grade 2 is a tightening, soft tissue around the joints tighten and tissue slack is taken up. The amount of movement or oscillation is varied and is based on the type and extent of joint pathology. Grade 3 is a stretch and additional forces applied to stretch tissue after joint slack is taken up. The amount of movement or oscillation varies and it's based on the type of extent of joint play. Then you have your Maitland grades. Grade 1 is a small amplitude oscillation performed slowly and parallel to the joint surface at the beginning of the joint range, and it's used to decrease pain. So these are your small isolations. You want to get little to no separation of the joint surface. Grade 2 is larger, slow amplitude oscillations parallel to the joint surface with available free range. And this is the decreased pain. So you get a little more separation from that joint, but you still want to go slow and you don't want to go too far with your separation. Grade 3 is large, slow amplitude oscillatory movements performed from the middle to the end of the available range of the joint. And this is used to increase joint range of motion. So with this one, you want to find how far you want to take that joint separation as far as you can get it. And then you want to go back off of that. That's going to be your end point. And then you don't want to let the joint go all the way back to the start. You want to let it go halfway and work in that zone. Grade 4 small amplitude movements up to the end of the available joint play, and that's used to increase range of motion. So same thing here. You want to with this one, you want to go to the end of the range as well, but you don't want to. You want to take it slow, and you want to go about from the 3/4 to the end. You don't want to go all the way back to the end, and you don't want to go back to the middle of the joint range. You want those oscillations to be small. You don't want them to be large like in grade 3. And then grade 5 is a small amplitude, high velocity thrust at the end of the available joint range, non-oscillatory, also called thrust manipulation. This is the one that you're not going to do repetitiously. So you're going to take the joint to the end of the range, and then you're going to give a hard thrust, either a distraction thrust or a compression thrust, depending on what you're trying to accomplish and which direction you're going. And then you're going to relax. And with that one, I'm a big combination guy. As most of you know, that I like to combine either different techniques or different modalities or different different manipulations together as one. What I like to do if I'm using a thrust manipulation, I'll use either a grade 3 or a grade 2 oscillation, and then I'll hold at a grade 5, and then I'll give that thrust, and then I'll take it down to a grade 1 oscillation, then back up to either a 2 or 3, and then do that 5 again. These are just some examples of different mobilizations and manipulations. So we have a subtalar distraction, and then we have a talocrural posterior glide. So that's to get range of motion back. The subtalar distraction is more for pain in that subtalar joint or that talocrural joint. The talocrural posterior glide is more to get that range of motion back in that joint, especially around that Achilles and calf area, to get that dorsiflexion up. You got a lateral subtalar glide. That's to get that range of motion for eversion or inversion. Then next we have a first tarsal metatarsal joint dorsal glide. That's to get that range of motion back in that first tarsal metatarsal joint. And then you have that TMJ rhythmic joint mobilization. That's from that's the study that was mentioned earlier. Just a small oscillatory mobilization to loosen that TMJ up from that TMD disorder. Next, we have a couple of tibial femoral glides. We have a posterior glide, another posterior glide, just with a different angle of the tibia. We have a lateral glide, a medial glide, and then another medial glide, and a patellar, actually a patellar, more of a patellar glide here. Just to get that, again, to get that range, these two are to get the range of motion back in flexion extension. And these are to loosen up any adhesions in that lateral medial side of that knee and around that patella. And then this bottom one is an acetabular glide. Notice he has the body strapped down to give him more leverage, and he's going anterior to get more range of motion back into that posterior hip. Here we have a lumbar mobilization to loosen up the facets in those lumbar vertebrae. You'll normally see that used when someone's having trouble with back flexion at the lumbar region. Here we have a first MTC mobilization for thumb injuries and people who have that lacking that range of motion in that first MTCP. We have a carpal mobilization. This is real good for anybody that's coming off of being immobilized from a fracture or a sprain or anything like that, to get those carpal bones moving and to get more range of motion in that wrist. We have acetabular distraction, and then we have glenohumeral traction. Gaps in future research. So a common thing I've seen with a lot of the research articles for this was the lack of RCT or rhythm control trials that use control groups. Most of them either had another intervention or they didn't have any control group at all. They just focused on the one, put everybody in the one group with the intervention that was being studied. And then the follow-ups. The follow-up times on a lot of these were real short, 1 week, 3 months. They weren't very long. Another thing was using grade 3 oscillations on different types of injuries to test that hypoallergesic response. Most of the grade 3s for hyperallergesic purposes were on knees, and future studies on different injuries on different body parts, so shoulders, ankles, elbows, would be really helpful in progressing the use of mobilizations. And then more studies involving distal upper extremities. So most of the studies found were on knees and ankles, chronic ankle instabilities, and shoulders, the glenohumeral, and a few elbows. But there needs to be more on upper extremity stuff, like the wrist, the hands, fingers, cervical spine, T-spine, so that we know how to properly do them in those areas and what the effects are. And then again, larger sample sizes with those treatments. And also so we know the true effects of manipulations and mobilizations, using them by themselves. A lot of these articles and research papers had them used with other modalities or other treatments. So it was hard to tell if it was actually the mobilizations and manipulations that were causing the effects, or if it was the other modalities and treatments. And then finally, determining the mechanical degrees of freedoms and how they incorporated into the strategies of movement. So using different angles with the mobilization techniques, with the manipulation techniques, to see if they change the outcomes of the study of what they're trying to accomplish. Learning assessment. Number 1, true or false? Joint manipulation does not involve thrust. Number 2, the 5 arthrokinematic motions facilitated by joint mobilizations are: A, roll, spin, slide, glide, compression; B, spin, slide, compression, distraction, roll; C, compression, roll, flexion, extension, contraction; or D, concave, compression, roll, spin, distraction. 3, true or false? Kaltenborn grading scale is a 3-part grading scale. 4, what responses are seen with the use of joint mobilizations and manipulations? A, increased range of motion; B, increased arthrokinematics; C, inhibited nociceptive stimuli transmission; or D, all of the above. 5, blank is not a contraindication for joint mobilizations and manipulations. A, hypermobility; B, hypomobility; C, effusion; or D, none of the above. I'd like to thank everyone for taking the time to view this presentation, and I hope everyone learned something. Thank you very much.